That looks right to everyone? Okay, great. So today I thought I would talk about non-invasive monitoring of intracranial pressure. One, because that's just a personal research interest of mine, and then two, because there are a lot of cases in which, even though we'd really love to have your invasive monitoring, we either can't or we're trying to decide whether to put in an invasive monitor or not. So with that, we'll start with talking about when to use non-invasive monitoring. We'll talk about different types of non-invasive monitoring. And then at the end, I'm going to talk quickly about two upcoming technologies that I think are really interesting. And hopefully we'll be able to at least test them out, if not actually use them. So we'll start with when to use non-invasive ICP monitoring. And I think, the most obvious reason is when there is significant danger to placing an invasive intracranial monitor. We have a lot of patients who are either in DIC or have a significant coagulopathy, where we feel like it's either very challenging to get the coagulation to a point where it's safe to place a monitor, or it's impossible. There's this other sort of group of patients that you, as neurosurgeons, probably don't see as much, but there are a huge group of patients who are at risk for developing elevated ICP, where we are sort of following them, and there's no clear indication for putting in an invasive monitor. But certainly there is a risk, either because of the underlying disease process or because of some medical thing that we are doing to the patient. So patients with anoxic brain injury, certainly patients with acute liver failure, those with intracranial infections or leptomeningeal carcinomatosis. And then something that we see a lot in other ICUs are patients with severe electrolyte derangements with, for example, severe acute hyponatremia, or initiating renal replacement therapy. So oftentimes for patients in particular who have severe uremia or severe hyperammonemia, what happens is the urea and the ammonia can cross into neurons. And so when you initiate renal replacement therapy and you're clearing the blood of urea and ammonia, what ends up happening is the brain is actually hyperosmolar for a brief period of time, and fluid actually goes into the brain. And so you can actually induce herniation in a patient with severe metabolic derangements about 20 to 30 minutes after initiating renal replacement therapy. And I'll show you an example later on. And then, of course, there's a significant group of patients where invasive monitoring just isn't feasible because of where they live, either because they don't have neurosurgeons, they live in low-income countries, or there is no ICU that is able to manage drains. And so I think some of this data actually comes from low and middle income countries where people are trying to use ultrasound as a surrogate when there is no neurosurgeon available. So with that, we'll start talking about different methods. So obviously, pupillometer is something that you guys are probably very familiar with. I don't have to tell you about the anatomical usefulness of a pupillary exam. It can certainly, depending on the location of the injury, it can help us sort of predict what's going on in the brain. And I think a lot of my older mentors would ask, well, why not just use a flashlight? Because a pupillometer is expensive, and I'll show you what it is in a second for those of you who are not comfortable or not familiar with it. But we know that standard examination of pupils is just inaccurate, both with poor inter and even intra-rater reliability. These are some examples when I was a fellow of when I was getting called and I asked for a pupillary exam. They're both reactive, but one is kind of sluggish. The pupils are both blown but reactive. His pupils aren't reacting, but my light isn't very good. So I really don't know what to do with any of these sort of comments. And I think in particular, when you're trying to sign out an exam to the next person who's taking over for you, saying something like one is kind of sluggish is really not a very helpful way of describing an exam. So for those of you who don't know what pupillometry is, it's this very weird looking gun looking thing, and it's got a screen, it's got a standard light on it. And so this is a normal eye of one of our nurses. But basically you point it and it releases a standard light, and then it's able to measure all these different aspects of the pupillary response. So the starting size, the minimum size of the eye, of the pupil, and then things like the velocity of the change, the percent of the change in size, the latency to starting a pupillary response, and things like that. And what it does sort of spit out is this thing called the NPI, which I'll talk about in a second, which I think we all talk about a lot, and is one of my biggest pet peeves personally. But you can see that over time, you can get quantitative data on the pupil, including both the accurate size of it and also how it's reacting over 3 seconds after being exposed to light. So is there any evidence for this besides just being able to document it well? So yes, in a lot of different disease processes, we know that a percent reactivity of the pupil of less than 10% correlates with elevated ICP in brain injury. We know that reactivity is more accurately assessed with the pupillometer, especially when the pupils are super small. So you can see here, orange and red are examples of mismatch where nurse or the physician disagreed with the pupillometer. And you can see that at really big sizes of the pupil, everyone sort of seems to agree, is it reactive or not reactive? But it's the very small, pontine or fentanyl pupils where we really can't tell whether the pupil is reactive or not. And then size, which is actually a really important thing to monitor, especially if you can keep the ambient light sort of the same in the ICU, is more accurately assessed with pupillometer, and that's in particular with in-between sizes. So everyone can identify 6 or 7 millimeter pupils. Everyone can identify 1 millimeter pupils, but then in between, we're sort of just making it up. So whether it's 2 or 3, really people have no idea. And so then what gets spit out by this machine is the neurologic pupillary index, or the NPI. And I've definitely been asked by people, what is the NPI? And the answer is really that no one knows. And I think that's personally sort of a problem. So it's a proprietary algorithm by the company that's made the pupillometer. And it includes things like the minimum and maximum size of the pupils, the constriction velocity, and the latency to initiation of constriction. But we don't actually know the weight that each of these things gets within the algorithm. And based on some studies, we know that an NPI of greater than 3 is considered normal. And we also know that just looking at the constriction velocity is not adequate for a normal light response. And so personally, I take a look at both the NPI and also the percent reactivity, because sometimes what we'll see is that the percent reactivity will drop first, and then all of a sudden the NPI drops. So I think looking at a combination is important. And I think really the most important thing, and this is something you're going to hear me say ad nauseum in this talk, unfortunately, is that trends are really important. And the nice thing about the pupillometer is that they can be reviewed. So this, you have access to this in the flow sheets, sort of at the very bottom of the complete flow sheet in the neuro ICU. And you can see, unfortunately, that the nurse has to document this every hour because it does not go automatically from the pupillometer into the EMR. But you can see at the top, there's the right pupil, and then at the bottom, there's the left. And you can sort of watch over time, both the percent change and then also the NPI. And importantly, you can also see the size of the pupil. And so, this is someone where they've gotten hypertonics several times. You can tell their pupil goes from like 2.5 to 6 with poor reactivity. Then even though the pupil comes back down, the reactivity is not that great still. And then it slowly comes back, and then they have another crisis here. So I think this is very helpful in the sort of nebulous pupillary exam when we don't have much else to go on. But there are limitations. So certainly patients with corneal surface disorders, it's unreliable. You also must be able to open the eyelid in order to test this. And so there are a bunch of trauma patients in which we can't really test this. And then, of course, there's the cost. And so the cost is fairly negligible to a big hospital system like ours, but certainly in smaller hospital systems can be prohibitive. So with that, we'll move on to the optic nerve sheath diameter, which maybe you guys have heard of, but probably are less familiar with. And so just to sort of review the anatomy, just to remember that the optic nerve sheath is actually continuous with the dura. And so that means that the subarachnoid space is continuous with this space that's sort of in between the optic nerve and the optic nerve sheath. And so once the ICP goes up, obviously the ICP is transmitted forward in the form of papilledema, which you can see. But it also causes fluctuations in the diameter of just the optic nerve sheath, where the sheath widens. But of course, you wouldn't expect that the optic nerve itself would change. And so this is how you measure it with just a vascular ultrasound probe. So this is actually something that was developed primarily in the emergency room, because those are the people who use ultrasound the most. And you can see here the sort of picture that you get. So this is the eyeball, this is the vitreous. This bright thing back here is the optic disc. And then here, you can't really tell the difference between the optic nerve and the optic nerve sheath. And you just measure 3 millimeters behind the optic disc, which is where the maximal fluctuations occur. And you measure the diameter. Now, that's a fairly normal optic nerve. This is an example of a patient we had, and there's a couple of things that are abnormal. So you can see here, there's elevation of the optic disc. This is the equivalent of papilledema if you were to actually look in the eyeball. And then you can see here, there's actually a distinction between the hypoechoic or dark optic nerve and then the optic nerve sheath. And you can see there's actually hyperechoic stuff in between. So you can tell the difference between the optic nerve and the optic nerve sheath. And the diameter is elevated. It's almost 6 millimeters. And so these are the sorts of things that we're looking for when we do optic nerve sheath diameter. There is data to support this. Not surprisingly, if you try to correlate the diameter of the optic nerve and ICP, there's no correlation because the optic nerve should not be changing size with elevations in ICP, but the diameter of the optic nerve sheath does. And this is just from a sort of review, and the cutoff, unfortunately, is not something that is universally agreed upon. So the cutoff, depending on the disease process and the study and how they measured the ICP, ranges anywhere from 4.8 to 6 millimeters. That being said, everyone has a different baseline optic nerve sheath diameter. Errol Gordon, who used to work here, famously has a baseline of 6 millimeters. And so certainly, the cutoff itself may not actually be all that helpful if someone baseline has a larger optic nerve sheath diameter. However, the trend can be very helpful. And so this is a study where they injected lactated ringers into a lumbar drain in patients who had had lumbar drain placement for NPH evaluation. And you can see as they injected lactated ringers, the optic nerve sheath sort of dynamically responded as well. And what they do say, though, in this paper, which I think has been forgotten since, is that because of a variable pressure diameter relationship, the subarachnoid pressure itself cannot be exactly predicted by a single scan. And so again, I think this is where the trend really helps. What we've also seen is that the optic nerve sheath diameter will drop after you treat elevated ICP. And so this is a study in patients who did have invasive ICP monitoring, and they concomitantly did optic nerve sheath diameters as well. And they did baseline when there was a high ICP, and then about 20 minutes after mannitol was infused. And you can see that there is a difference. Now, the amount of change doesn't necessarily correlate with the amount of change in the ICP, but it does dynamically respond. And so it does give you an ability to sort of check and see if your empiric medication treatment has actually helped or not. Again, there are limitations to this as well. It's like everything that is ultrasound, it's operator dependent. It cannot be used in cases of severe orbital trauma, or theoretically, if a patient were to have an optic glioma, for example. But then also, if you don't know what the baseline optic nerve sheath diameter is, it can be difficult to interpret. So then we'll move on to transcranial Doppler, my personal favorite. So just remember that the TCD waveform is going to sort of mimic your arterial waveform. And the things that I want to just point out are that remember that you need to have robust diastolic flow. Unlike in most other organs of your body, the brain needs to have flow during diastole in order to function properly. And so this is a really nice picture from a review where they discuss what happens as you increase your ICP and you decrease your cerebral perfusion pressure. So normal, you see there's a nice robust diastolic flow. You really shouldn't be able to tell much about systole versus diastole, except maybe right here. As the ICP increases, there's impedance of diastolic flow first. And so you can see this waveform changing. And we talked last time I did a pearls about TCDs. We talked about the pulsatility index, which is basically the difference between systole and end diastole. Eventually, your diastolic flow reaches near zero and then zero. And when it reaches zero, this is where your ICP equals your diastolic blood pressure, and you're just getting systolic peaks. Then you'll start to get triphasic flow, where during diastole, you actually have flow in reverse, backwards. And eventually, as you progress to cerebrocirculatory arrest, you will have only backward flow during diastole and very brief forward flow during systole in what we call oscillating or reverberating flow, and then systolic spikes where there's really negligible forward flow. Can we calculate the ICP from TCDs? People have been trying this for 20 years and no one has been successful yet. And so again, this is something where your data does not necessarily give you a number. So it's not as nice as having an invasive ICP monitor where you know that the number means something. But again, the trend may be useful. So this is a patient with acute on chronic liver failure who had acute hyperammonemia develop within 12 hours. Where the ammonia went from 64 to over 500. Unfortunately, this patient was on Versed and ketamine, and even low-dose ketamine in a liver patient can cause you to lose your reflexes just because of the impaired metabolism of ketamine. And so with these labs, we did not think that it was going to be safe to even ask for an invasive ICP monitor. And you can see that there is clear cerebral edema on his CAT scan with poor gray-white differentiation. And had I shown you a pre-CT, you'd have seen that this chronic liver failure patient actually had quite a bit of atrophy to begin with. And so we tried to do TCDs, and you can see that the pulsatility index was, even if you don't know what the number is, you can sort of see that through most of the cardiac cycle, there's very poor flow compared to during systole. And he was initiated on CVVH in order to clear ammonia. And you can see that we trialed multiple 3% boluses, started a 3% drip in order to bump up the sodium. And over time, you can see that the generation of ammonia was actually overcoming the clearance of ammonia by the CVVH, where his ammonia went up to 650. And so at that point, we were asked, is it safe to initiate HD? And as I sort of intimated before, that can be a very dangerous time, especially if you're going to just do HD, because the clearance is so fast that you really can worsen elevated ICP. And so what we decided to do was try to initiate the highest flows that you can initiate on CVVH in order to try to maximize clearance of ammonia without actually, doing proper hemodialysis. And you can see things were getting worse. And then 20 minutes into higher flows, the pulsatility index goes from 1.7 to 2.1. We give him 23. And within 5 minutes, this is what his TCDs look like, which are much more normal than he had, frankly, even before we had changed the CVVH. So again, while the data itself can't necessarily be calculated into a number, we can use continuous TCDs to sort of give us a sense of whether things are going in the right direction or the wrong direction. And then also, we gave 23%, and had we not had TCDs, we wouldn't have had pupils to look at because of the ketamine to understand whether it was working or not. So this gives you a nice example of how you can sort of monitor. Again, limitations, TCDs are operator dependent, especially if you are not TCD trained. It can be very challenging. Anywhere from 10 to 20% of patients have poor bone windows in the temporal bones, which can limit how well you can use it. If there are vascular abnormalities, it can limit how to interpret. And so you really do need someone who's trained in order to be able to interpret the flows and the pulsatility. Waveforms can be affected by a lot of things, including, anywhere from cardiac valve disorders to the use of vasopressors. And then we really, at this point, don't know properly how to calculate a proper CPP, ICP, or autoreactivity. And so it really requires someone who knows what they're doing, being actively involved, and it's not really at the point where we can automate things yet. And then I just, briefly want to talk about quantitative EEG, because I think we sort of sometimes forget that EEG can be used for things other than looking for seizures. Remember that EEG is really just telling you about the function of neurons. And so as your cerebral blood flow drops, you start to see first loss of faster frequencies as you transition into anaerobic metabolism. Then you get increasing slower frequencies. And then ultimately, as the neurons are getting ischemic, you start seeing these like very slow delta waves. And once the actual neurons are infarcted, that's where you get total suppression. This is in the absence of sedation, obviously. But so we can use EEG to look for changes related to elevated ICP, because as the ICP goes up, the neurons are essentially getting ischemic, right? Because of poor cerebral perfusion pressure. So you can see this in the raw EEG, and that's sort of at the bottom here. But quantitative EEG can help detect this more easily, especially to the untrained eye. And so quantitative EEG has been, suggested to be a sort of neurotelemetry. So basically the software creates these mathematical analyses. And so you can see here, for example, there's the spectrogram. So it's telling you about the quantity of different frequencies from low to high. This here is telling you about suppression, and it's actually detecting suppression. And then this is just overall power down here. And so this is a patient who had an elevation in ICP at the time of this purple box. And so you can see that there's a power alarm that drops off. And then slowly there starts to be increase in suppression, which briefly gets better as they try to treat with some mannitol, but then ultimately they fix the drain and things start to get better after this. And so you can see that like in the raw EEG, it does look like faster frequencies start to drop out and then slow frequencies start to become predominant. But certainly this is something where you don't necessarily need to be trained in how to interpret EEG in order to be trained in how to interpret quantitative. And so I think, this is where TCDs probably should be going soon. But this can be a very helpful tool at the bedside to identify when there is an issue. Obviously, severe metabolic derangements can affect your EEG and cause things like slowing and suppression. Sedation certainly can, and there are a bunch of patients where they may have elevations in ICP despite significant sedation. And so this isn't really a cure-all, but it is something that can be used sort of in conjunction. And then I quickly wanted to talk about two really cool technologies that are upcoming. There are definitely many companies that are trying to figure this sort of stuff out. This is something that has already come out. It's called Brain for Care. And what it is apparently there are very micro deformations in the skull due to pressure variations. And this is supposedly able to pick them up, amplify the signal, and filter in order to display what they call a surrogate ICP waveform. And so it's really just a headband with a sensor. It can be used even in patients who have other things on their head or on their neck. This was a patient who, on admission for meningitis, you can see there's this very non-compliant waveform where the P2 is higher than the P1. If we saw this on the EVD, we would be concerned about this. After the LP, they put it back on, and you can see the compliance is better. And after 8 days of antibiotics, you can see that things are much more normal. And so again, there's a lot of proprietary algorithms that are going into this, but this does seem to be something that may have some promise. We don't know a ton about how this is affected, for example, in patients with hyperostosis. They claim that you should be able to use it on everybody, but we really don't know that quite yet. And certainly the headbands are made for older children and adults. And so, this is not something to be used in small children yet. And then the other cool technology that's coming out is tympanic membrane pressure waveforms. And so really it just looks, you put these measuring things in the canal, and it looks like the patient is, listening to tunes. And what it's really doing is measuring the movement of the tympanic membrane. And as the ICP elevates, there are actually, you can see ICP waveforms, supposedly, if you can filter and augment what this is detecting. And so this is just an example of a couple of patients where there's obviously a lag between the actual ICP waveform as invasively measured, and then what is measured within the ear canal. But if you sort of reduce that lag and superimpose them, you can see there's some promising stuff. And so, again, this is a very non-invasive tool. Again, there are a couple of limitations. You need to be able to make sure that the ear canal is patent. And so it may not be able to be used in trauma patients or in patients where we're concerned about watching for CSF leaks through the tympanic membrane. But I do think that there is promise in probably the average patient that we would be using this for. And so with that, just some final thoughts. Non-invasive measures of ICP may be useful, but it seems that for most of these things, the trends are probably more useful than a single measurement. And I'd say that probably part of the reason is that for all of these things, we're not actually measuring the ICP itself, we're measuring the effects of a high ICP, whether it be because of flows on TCDs, or actual compression of the third nerve, or whether it be through, actual functional changes within the brain itself. Obviously, there are a lot of challenges in researching these methods because a lot of the patient populations that we would like to use these in are patients where we can't put in a gold standard ICP monitor. And so we're necessarily going to be extrapolating data from disease processes where it's indicated to place an invasive ICP monitor, but those might be processes that are not applicable to more global processes that we might be concerned about. So a patient with a big ICH may not have the same changes on non-invasive measures that a patient with global cerebral edema from acute liver failure has. And so we have to be cautious about how we are interpreting the data. And then most likely it's going to be using a combination of methods, or what I call a bundle of methods for monitoring elevated ICP. So if you're seeing 2 or 3 things sort of going in the wrong direction, that may be a little bit more accurate than if you sort of just use only one monitor and sort of put all your eggs in that basket, just because of the challenges and the limitations in all of those methods. And with that, thanks. I hope it wasn't too boring for those invasive ICP monitors that you are.
I think this is a great opportunity, having all of these technologies to monitor patients who we previously couldn't monitor is tremendous. Have there been many correlative studies of invasive ICP monitoring with non-invasive measures in large populations?
There are a few really good ones. Most of them happen to be in trauma, which again is sort of a very different disease process. And I don't think we're going to be saying that trauma patients are not getting invasive ICP monitors, at least in the US, anytime soon. So there are some. I would say that in general, there tends to be sort of like a heterogeneous population, which again makes it very challenging to interpret, because a lot of these non-invasive monitors are sort of measuring global ICP rather than compartmentalized ICP. And so I think that's the main challenge. In other disease processes where there is no invasive ICP monitor, it's sort of been more of a correlation of worsening. And I think one thing we need to sort of look for is identifying patients before they have the elevated ICP and when they're really non-compliant, which I think is what that headband is sort of claiming to do. Because I think that's really where you want to be able to identify patients and sort of increase their level of monitoring, rather than once, you know, they've blown a pupil or have poor perfusion to their brain.
Thank you.
Cool.
Does
Thanks.
anyone else have any other questions? Okay, we'll move on to spine conference. Ray, I'll turn it over to you.